Hello. This lecture is about infection control in healthcare settings with a public health focus. My name's Trent Yarwood. I'm an infectious diseases physician from Cairns. I would just like to begin by acknowledging the traditional owners of the land on which we live, work and study, which for me are the Jabbergai and Yirraganji people of the northern beaches of Cairns. As I said, I'm an infectious diseases specialist. I work at Cairns Hospital and Cairns Sexual Health, but this lecture is in my personal capacity and not on behalf of Cairns and Hinterland Health Service or Queensland Health. You can see that I've worked in a variety of roles in clinical infection, public health, and in antimicrobial stewardship, including a number of state and federal advisory roles. And antibiotic stewardship and infection prevention are among my clinical interests, along with HIV medicine. I've got no conflicts of interest relevant to this talk. Infection control is obviously about the prevention and control of healthcare associated infections. We prefer the term healthcare associated infections over healthcare acquired or the older term nosocomial infections, as modern healthcare has changed quite a lot, and not all infections that are related to healthcare are necessarily acquired in a healthcare setting. Obviously, patients who are now receiving outpatient chemotherapy via a PICC line or other hospital in the home type care can acquire an infection that's related to their intravenous access device and be at home. So calling it hospital acquired is clearly not correct. More than 200,000 healthcare associated infections occur in Australia each year. We estimate that around 12,000 of these are bloodstream infections, and of those around 7,000 are Staphylococcus aureus bloodstream infections, which even with best modern hospital care still have a mortality of somewhere between 15 and 30%. Another way of looking at it is that around 25% of patients who have a hospital admission will develop some sort of healthcare associated infection. So we're talking about very large numbers and a very significant burden of morbidity and cost for the healthcare system. There is significant overlap between communicable disease control and infection control, and the work that CDC public health nurses and infection prevention and control practitioners do is really very similar. Often there is much more of an artificial barrier between the inpatient and community health roles, because a lot of the functions that they do, for example, contact tracing and outbreak investigation and management, are really very similar. Adding some complexity is the fact that in Queensland, at least, authorised officers under the Public Health Act, who are usually environmental health officers working in the public health units, are also the people who are responsible for the inspection of healthcare facilities and the enforcement of the requirements of infection control management plans. Now, in the community, this happens in businesses like tattoo parlors and piercing studios and other similar places, but it's, I guess, a legislative complexity that the public health units in Queensland are part of hospital and health services, and that therefore you've essentially got a body regulating itself. Because the public health units were historically separate from the hospital and health services, and their functions are still seen to be quite separate, this, I guess, is really more of an on paper than in practice obstacle. One of the other things which I'll talk about later is that drug-resistant infection is really a community health issue. Although we see most of these infections in hospital, the carriage of the organisms really occurs in the community, and we are certainly seeing an increase in the number of drug-resistant infections in primary care. And I think that there's a lot of value for greater involvement of public health in the management of drug-resistant infections. As I said on the last slide, infection control is challenging. Hospital clinicians, so people other than infection teams, pre-COVID at least, got very frustrated by infection prevention. It was seen to be bureaucratic and getting in the way of patient care. Why do we have to do all this sort of stuff? And really, I guess, was undervalued compared to the utility of the services it provides. Hopefully COVID has changed that a little bit, and even more hopefully the increase in profile will be sustained. As I said on the last slide, there's a sort of what I call the Great Wall of Inpatient, where even though the work is fairly similar, there is very firm division between public health and infection control work. And I've certainly had public health physicians say to me, oh, well, that's nothing to do with us, that's up to you, even though the management of, say, a case of varicella in the waiting room of an antenatal clinic clearly has community as well as hospital impact. But the important thing is that all of the work, regardless of the location that it's done, is about preventing infection, and we really need to focus on the benefits that come to patients through avoiding infections that might otherwise occur as a result of healthcare or otherwise. Following on from that last slide, I guess it's just worth highlighting the differences rather than the similarities in practice. Obviously, public health, at least initially in the pandemic, had an interest in case finding, so screening as many people as possible and trying to isolate those people who had COVID to prevent the onward transmission, especially to vulnerable settings. Whereas infection prevention and control also have that same preventing infection in vulnerable settings focus, or the hospital being a vulnerable setting, but with the priority of preventing transmission to other patients in hospital and also to staff as a patient safety activity, as a staff health and occupational health and safety issue, and also when early in the pandemic, when we thought things were going to be a lot worse than they turned out to be in terms of inpatient load, to try and maintain safe and effective hospital services for people who had COVID or people with other unrelated medical conditions. I have a few slides with a little history now. In the 1300s, the Venetians came across the idea of cohorting infected patients. Now, this was good infection control for the time, although it was done for the wrong reasons. This was when the prevailing theory of disease was either miasma or bad air, which is indeed where malaria gets its name. So it wasn't for a good number of centuries after that there started to be further understanding of the benefit of infection prevention. As with many medical advances, the military had a sort of an important role in the development of medical thinking, predominantly from the point of view of keeping soldiers on the battlefield. If you had one single field hospital that had a few people with dysentery and a number of soldiers with war wounds, then it was potentially problematic because your other soldiers would get dysentery as well and potentially be off the battlefield. And it was really done with a focus of making sure that healthy-ish people stayed healthy and could therefore get back out to fight as soon as possible. It was also the 1700s when there started to be increasing awareness of the potential role of overcrowding of hospitals in the transmission of disease between patients. In the late 1700s to mid 1800s, there was awareness of puerperal sepsis or childbed fever as a contagious disease, and I'll speak a little bit more about that a bit later on in the context of the work of Semmelweis and his sort of development of theories of hand hygiene in the mid 1800s. It was the mid 1800s were a busy time for infection and public health. It was also the time that Lister developed his technique for surgical antisepsis with carbolic acid, John Snow and the Broad Street pump, and later in the 1800s, the use of reusable gloves in surgery to prevent or to reduce the likelihood of surgical infection. As I said before, healthcare has changed a lot, particularly in the last 20 years. We are now doing a lot more complex and intensive medical care than we did previously. So transplant immunosuppression is much more heavy than it used to be to allow a greater rate of transplants with less well-matching organs. We're delivering much more myelotoxic chemotherapies, sometimes as an outpatient, via patients coming to day chemo units. And all of this increasing complexity of care is also in the setting of increasing drug resistance in bacteria, mainly, and the emergence of new infections, as we've seen with COVID, and both of those factors on top of the fact of increasing global travel, such that an outbreak of a novel infection in somewhere in the world can relatively rapidly spread and find new hosts in many other parts of the world very quickly, particularly as we've seen with the monkeypox outbreak this year. Parallel with that is an increasing focus on quality and safety in healthcare. So considering that the important ethical and sort of moral imperative we have to provide this technically complex healthcare without causing additional harm to patients. I'll talk a little bit more later in the talk about the development of the list of what's called healthcare associated complications and the, I guess, mixed utility of financial incentives to try and reduce these rates of complications that have really come about through this sort of safety and quality lens that we're now looking at healthcare through. For me, the important message of infection control is first no harm, or primum non nocere, which people commonly think is from the Hippocratic Oath, but is actually not. Hippocrates said that doctors should swear to abstain from doing any harm. And really the nuts and bolts of it for me is that, as I say, we have an ethical and moral responsibility to provide care to people who need it, but to do so in a way that doesn't result in them suffering additional harms, or at least to minimise the number of additional harms that occur. So I'll talk a little bit now about some of the functions of infection control, and then sort of step through a few of the big areas that we consider to be parts of infection control programs. I won't labour the point of talking about the surveillance cycle, which is on the next slide, because many talks that I've been to about infection control spend a lot too long talking about it. However, it is really important to know about, though, and also to put in practice, because we need to measure what we're doing to see whether what we're doing is making any difference, but also to allow reporting, which may be required by legislation or statute, but also so we can provide feedback to justify the work that we're doing. Now, people who work in infection control will frequently report that they spend so much time doing data monitoring and surveillance that they sometimes feel like they can't actually spend any time doing clinical infection, and that's a real challenge, sort of a balance that we have to find between clinical work and data management. The surveillance cycle is really important, though, because we need to have an understanding of what's happening with infection in our hospitals before we can prevent it, but also before we can know that the preventing that we're doing is actually being effective. So, it's of critical importance to measure what it is you're trying to improve, to come up with a plan based on those measurements, to implement your plan and then reassess and evaluate so you can see if your plan is working. As with community public health, the measurement is a lot more difficult than clinical medicine often tends to be, because cardiologists can tell you how many angiograms they've done, and gastroenterologists can tell you how many scopes they've done, that sort of thing. There's countable outcomes, if you like. Whereas prevention of disease, you can measure the number of diseases that you've prevented if your rates are going down, but when things are as good as they can be, there's an unknown number of cases averted that you can't measure in any other way. So it might not look like you're doing very much, but the answer is, well, it would be much worse if we weren't here. Well, how much worse would it be? Can you tell us? And that sort of unmeasurable nature of prevention is a real struggle in terms of justifying the business and the work of infection control programs. Regardless of the justification and the measurement, it's also really important to be collecting data so that you can feed back to your clinicians and talk to them about the issues, talk to them about the management strategies that you've implemented, and involve the clinicians and the other people outside of the infection control team in designing your infection control interventions. I very firmly believe that public health thinking is very important in infection prevention and control. I think there's not enough public health thinking in acute hospitals, and similarly, there's sometimes not enough clinical thinking in public health units. But as I said, measurement needs good data, and as records become digitized and as activity-based funding creates other reasons for us to be monitoring what's going on in hospitals, there's been a very strong tendency for people to say, well, we can use this sort of data that we're already doing to infer our infection rates and our prevention activities, and that will hopefully make it easier on everyone. Now, while this can be an attractive proposition, you've got to be careful. So, this is no shade on the clinical coders who do a great job with, often very poor quality medical records. But assuming, since all that coding is happening, that this accurately reflects infection rates can be dangerous, as I've given with this example here. We did an audit in my hospital of 21 patients who were tagged as having a bloodstream infection, and on careful review of the notes by an infection control practitioner and myself, we found that 13 of them in fact did not have a positive blood culture at all. 4 of them had contaminated cultures, so not considered clinically significant. 1 of them did indeed have a bloodstream infection but was onset in the community. And the remaining 3 did actually have healthcare associated bloodstream infections. And so, for 3 out of 21 cases coded as having a bloodstream infection to be accurate healthcare associated infections is really quite concerning, particularly as I mentioned on a few slides ago, that one of the ways of improving hospital rates of infection at the moment is felt to be offering financial disincentives. So if you have too many infections, then we'll start fining you for them. So that will encourage you to to reduce your, to improve your processes so that there's fewer infections. And so if you can see that you're being fined for 20 infections, but only 3 of them are legitimately actually infections, some people in your hospital's finance department are going to be asking some difficult questions. I won't labour the point, but this is the list of healthcare associated complications from the Commission for Safety and Quality in Healthcare. You can see that any healthcare associated infection is actually listed there in item 3, but there's a number of items that, while on paper it looks like it should be easy to say, well, this obviously should be a never ever event, like a pressure area, for example, that in practice it's much more difficult to prevent all of these. Just using a couple of examples, so cardiac complications include all in-hospital heart attacks, heart failure, arrhythmias, and cardiac arrest. So, obviously in a cardiology patient who gets admitted with acute angina, them going on to complete a heart attack while they're in hospital is something that probably shouldn't happen. However, a patient who's in hospital for another reason and sepsis, say, who spontaneously develops an arrhythmia like rapid atrial fibrillation because they're unwell, that is not an unreasonable complication to have happen from someone with severe sepsis, but the argument seems to be that that should also be a never ever event. And so I'm not 100% sure that all of these events could be prevented. In fact, I'm quite sure that 100% of them can't be prevented. Those of you who have worked in midwifery will know that despite optimal obstetric management, sometimes complicated perineal tears can just happen. Similarly, delirium, particularly in frail elderly patients from nursing homes who come in with any medical condition, are at significantly increased risk of developing delirium. And the saying that this is a never ever event is really not entirely realistic. The discussions around financial disincentives were essentially designed to get hospitals to improve their act. So, if you have too many cases of these hospital complications, we will reduce your funding, and therefore that will encourage you to do things better. Now, aside from the logical inconsistency of saying, here, have less money in order to do things better, The private health insurance companies have also jumped on the bandwagon and said, well, we're not going to rebate for these complications because they should be never ever events. And so the example being, if you are in your private hospital for an elective hip replacement and you fall out of bed, then they're not going to rebate for any of the costs of doing any assessment or management, CT scans or whatever related to the fall, because that should never have happened. What does that mean in practice? It means that if a private hospital patient has any of these never ever complications and the health fund isn't going to pay for them, they pretty quickly get sloughed off to your local public hospital, because the public hospitals will do them for free. So moving to infection control proper now. This is a list of some of the components of an infection control program. There's probably more that I've left off, but I guess these are the important ones and the ones I'll be at least mentioning today. Hand hygiene is very important and has a few slides coming up very shortly. Discussion of PPE and patient isolation. Surveillance of infections, so as I've already sort of talked about with the surveillance cycle, to monitor and prevent infection. Some of the aspects of staff health that we end up doing. Oversight, but not necessarily direct responsibility for hospital cleaning, disinfection and sterilisation. Outbreak investigation and management I won't touch on very much today, because that's similar to a lot of the other public health issues that you've been learning about in this subject. And I will talk briefly about antimicrobial stewardship, but I also have another presentation to give on that in more detail. Hand hygiene. So many of you will have heard of Ignaz Semmelweis. If you haven't, then I will tell you the story, because it's a great infection control story for a couple of reasons. So Dr. Semmelweis was, I guess, the equivalent in the 1850s of the chief obstetric registrar at the maternity hospital in Vienna. He was the assistant to the professor and sort of did organisation of doctors' rosters and teaching and all of the things that senior trainees do in modern hospitals. Now, one of the things that Ignaz Semmelweis noted was certainly not news to the mothers of Vienna, which was, if you went to have your baby on the day that the doctor's clinic was admitting, you were much more likely to develop childbed fever than if you went to hospital on the days that the midwife clinic was admitting. And so you can see that in the graph there. The pink line, first clinic, is the medical clinic, and the second clinic, the blue line, is the midwife's clinic, that the rates of puerperal sepsis were substantially higher amongst the women who delivered their baby with the assistance of a doctor rather than a midwife. Semmelweis's light bulb moment came when one of his medical colleagues developed an infection that looked very much like childbed fever or puerperal sepsis, but he obviously hadn't had a baby because he was a man. He had nicked his finger with a scalpel while he was assisting in an autopsy. So remember that the 1850s were prior to Pasteur's work on the germ theory of disease and van Leeuwenhoek. And his theory was that there was some sort of mysterious cadaverous particle which were being transmitted by the hands of the medical staff. And this was because the routine for the doctors was that they would do their anatomy lessons in the morning. They'd be in the morgue doing autopsies and pathology and anatomy study. And then after lunch, they would go to the maternity ward and deliver babies. So Semmelweis's theory about these cadaverous particles was that they came from the morgue and from the dead bodies. They got in if you nicked your thumb with a scalpel, or they were transmitted on the hands of the doctors to the labouring women. And he therefore required the medical staff to rinse their hands in a bucket of chlorine bleach, essentially, chlorinated lime as it was called, prior to assisting with any deliveries. And you can see from the graph there that following the introduction of this hand wash where the red line was marked, the rates of puerperal sepsis dropped abruptly. Now, as I said, this was prior to germ theory, and Semmelweis's hypothesis went against the prevailing wisdom of the day in terms of medical causes of disease. So people were still believing that disease was either caused by miasma or by an imbalance of the bodily humours. And there was also an interesting social challenge that Semmelweis had to come up across. And what this was the fact that washing your hands was a marker of being of the labouring class. So if you worked in a coal mine or mucked out a horse stable or did any of those sort of dirty jobs that the poor did, then your hands would become visibly soiled, and therefore you'd have to wash them because your hands look dirty. Doctors were gentlemen. Of course, they were almost all men. And because they didn't do any of that common labouring, their hands didn't become dirty, and therefore they didn't need to wash them. So washing of hands was seen as a marker of being of the working poor. And so his theory and his suggestions that doctors therefore had to wash their hands like the commoners really didn't go down very well with his colleagues in the time, and he was perhaps not the best at communicating his ideas in a way to make his listeners very receptive. As you do, Semmelweis wrote to a number of the prominent medical journals of the time and said that what he had instituted as standard of care in his hospital in Vienna should become standard of care everywhere, and that if other people didn't do it, they were negligent and were potentially murdering women who were under their care. It may not come as a surprise to you that people didn't like being told that they were murderers, not doctors, and because of this strong social stigma that his theory was going against, it didn't get a lot of traction. Those of you who know much about medical history will know that Robert Virchow was perhaps one of the greatest doctors of his time. He was a contemporary of Semmelweis, and he basically said, "Oh, this sounds like nonsense. It's clearly not, doesn't fit with what we know about humours and miasma, and therefore it can't possibly be correct." And if Virchow says you're not right, then you're really pretty much done and dusted, and nobody's going to believe you. So when it came time to renew Semmelweis's contract, he was not renewed. He was invited to seek employment somewhere else, but because of his somewhat angry rantings to the medical journals, he was really not able to get employment anywhere. What happened after that is subject to some myth, legend, and speculation. But it seems he was not deterred, and in fact became more strident in his advocacy for the health of women, and started writing even angrier letters. Now, people theorize that he developed some frontal lobe disinhibition, which could have been dementia. It may have been syphilis, which was very popular at the time. But whatever it was, he became increasingly strident and basically wrote letters to journals calling his colleagues murderers for disregarding his obviously life-saving intervention. One of his mates, and I use the term advisedly, wrote to him and said, "Ignatz, mate, there's this insane asylum nearby that's doing some really good work on hygiene, and I think is very relevant to your work. I think you should go and check it out. Why don't we go and visit?" And they did. And while they were there, his friend signed all the paperwork to have Dr. Semmelweis committed to the asylum. Ignatz realized what was happening, but perhaps a little bit too late. And the story is that he tried to escape, was beaten up by the guards who were stopping him from leaving the insane asylum now that he'd been committed. And the story goes that he either had a laceration or a hematoma from his beating, which became infected and resulted in getting sepsis and died. So it's entirely possible that Semmelweis died of the disease that he had saved so many women from. Two lessons. Number one, keep at it, because sometimes you being right doesn't necessarily come to fruition straight away. But if your method of communicating your views to other people is to tell them that they're a bunch of murderous dickheads, you're probably not going to do very well for very long. And that the way you deliver the message is sometimes as important as the content. So Semmelweis's legacy of hand hygiene is widely acknowledged as the most important measure for preventing the spread of disease. It is still controversial, though. You can see from the table there that in various audits, compliance with hand hygiene in different settings varies somewhere between 16 and 80%. Hand hygiene, while theoretically cheap and easy, is not very well done in hospitals, unfortunately. And it's really an ongoing maintenance program to continue reminding people of the importance of hand hygiene. The WHO now has significant resources. Their Centre for Patient Safety has a global hand hygiene campaign led by Didier Pitet, who's one of the authors of the paper that table originally appeared in. So you'll hear a lot of talking about the 5 moments for hand hygiene, which are listed there. So before touching a patient, before doing a procedure on a patient, after you've done a procedure or had a body fluid exposure risk, so for example, handling a catheter bag or examining a patient's wound or doing whatever, after touching a patient, even if no procedure was done, and after touching a patient surrounding. The 5th one is specifically designed to, cover the idea of walking into the patient's room, picking up their drug chart, having a read of it, putting it back down and leaving without actually touching the patient. Now, this might seem obvious, but the rationale for the moments is primarily about stopping your germs from getting onto the patient. Now, it may not be surprising that healthcare staff, particularly doctors, have the highest compliance with the moment that occurs after touching a patient, because we have the subconscious feeling that we've touched the patient and we want to get their germs off our hands. Now, that's important because those germs which transiently end up on your hands can then be transmitted to your next patient, which is super important because the pre-patient contact hand washing is much less well done than the post-patient contact. So if you examine your patient, you get their transient flora on your hands, you go to the next patient, you can transmit it to them. So the key, they're all important, but the key moment is before contact with the patient, because you're protecting the patient from your germs or someone else's germs who you've transiently acquired, not so much the other way around. Most of the infections occur not necessarily from our normal skin flora, but from these what we call transient flora. So things that are in the environment, particularly in hospitals, in a much greater frequency than they are outside hospitals. Predominantly things like gram-negatives, Klebsiella and E. coli and other gram-negatives, which get onto our hands and we then transmit from patient to patient. So healthcare workers are an important vector of healthcare-associated infection, and washing your hands before patient contact as well as after patient contact is a crucial method in controlling it. An important part of hand hygiene programs is observation and auditing. Many of you who work in hospitals may be familiar with the infection control team previously, who stood around with clipboards and who now stand around with iPads, just watching people walk up and down the corridor and checking whether they wash their hands or clean their hands before and after, at every moment opportunity. Compliance with a moment is considered to be using soap and water hand washing or alcohol-based hand rub, and there are requirements for collecting a certain number of moments in a particular clinical area to carry out a valid audit. You'll see there a snip from, I think it was the Sydney Morning Herald, reporting that it was terrible that doctors neglect washing their hands when no one's looking, which is a sort of a journalistic take on what's known as the Hawthorne effect, which is that people adjust their behaviour when they know they're being observed. Now, I don't necessarily think that's a huge problem, because what we want is people's compliance to be as high as possible. And so if people think that the infection control nurse is there and is auditing them, then they wash their hands, and that's good because there's more hand washing going on. Obviously, we would like there not to be as big a dip when people are not being observed, but it's about sort of instilling good habits in people. Hand hygiene is the first of a couple of multimodal interventions that I'll talk about. And so essentially what that means is that there's not one simple solution to getting people to wash their hands more. You need to do a variety of different things, and each of those contribute to improving your hospital or your other facilities' hand hygiene rate. Access is really important. The easier it is for people to wash their hands, the more likely they are to do it. And as I'll talk about in a sec, that's a really important part of the role of alcohol-based hand rubs. Auditing, as I've said, and feedback to clinical areas, not only providing feedback to the area saying, hey, look, you really need to pick your act up with moment 1. Moment 2 is pretty good, but you're not washing your hands before you see patients. So we'll see if you can work on improving that. We'll do some education, and we'll come back and audit again in 3 months. but also thinking about auditing outcome measures. So hand hygiene compliance is, I guess, a process measure. So, are people following the process of washing their hands? But one of the things that we do in terms of infection surveillance is in monitoring the rates of Staph aureus bloodstream infections, and they're shown to be quite well linked to the compliance with hand hygiene in your facility. So it's not only just about measuring the hand washing, it's about showing that there's other factors that are clinically relevant that are directly related to the frequency of hand hygiene. Cleaning hands which are visibly dirty is important because the dirt harbours more bacteria and makes the effect of the antiseptics work less well. Plain soap hand washing isn't recommended in healthcare facilities because it has some effect in removing the transient flora through the mechanical scrubbing, but it can also actually increase the number of normal skin flora that are recovered from the back of the hands, and that's predominantly through an effect of opening up the pores a little bit through the mechanical action of scrubbing, and some of the the skin flora jumping out of those pores, if you like, and being on the hand. So the data about that is a little bit mixed, but not just plain soap hand washing for clinical hand washers. One of the other benefits of alcohol-based hand rub is that alcohol is very effective at killing bacteria just through chemical action on the cell walls and works very quickly, and I'll talk about that in a sec. One of the other rationales for using products like chlorhexidine is that it has a direct disinfecting effect when it's on the skin, but it also has what we call a persisting post-antibacterial effect. So it has some disinfection that remains on the skin, and so the bacterial counts on people's hands remain lower for a period of time. It's not just about that mechanical action of cleansing the hands and getting rid of the transient flora. Now, you can argue about how well fitting for that graph that line is, but it's not much of a surprise to say that the biggest barrier for healthcare staff washing their hands more is time. So a good clinical soap and water hand wash should take around a minute in order to make sure that you've cleansed all of the areas of your hands, the webbing between your fingers and sort of the commonly missed parts like the back of your thumb and the difficult to reach parts. Now, if, say, for example, you work in intensive care and you have intense contact one-on-one with a patient who's got lots of devices and tubes and things hanging out of them, so there's lots of those potential body fluid exposure risks or lots of procedures being done, it's not impossible for a nurse to have 40 hand hygiene opportunities per hour. And if you're doing a soap and water hand wash, that means you spend 40 minutes out of every 60 washing your hands. Now, clearly, that's not something that's actually practically possible. You're not actually going to do any patient care. You'll just be standing in front of the sink for the entire time. You can see there in the graph that 70% alcohol-based hand sanitizers are actually more effective in terms of the reduction of numbers of bacteria on the hand, which means, for those of you who have been paying attention to efficacy versus effectiveness, that they're more efficacious than soap and water. However, as well as being more efficacious, they're actually more effective in practice as well because of that time issue. So it takes sort of squirt, squirt, walk while you're rubbing your hands together, providing you're getting good coverage over your hands. You can sanitize your hands using hand rub in the amount of time it takes to walk between the door of your patient's room and their bed, as opposed to spending a minute standing there with soap and water. So that means that hand rubs are not only more efficacious, they're more effective as well. The added bonus is that they tend to cause less hand irritation. So alcohol obviously irritates dermatitis if you've got it, but over a long period of time, you're much less likely to cause sort of contact dermatitis from hand washing or from hand hygiene with a hand rub than you are from soap and water. That's enough about hand hygiene for a bit. I'm going to talk about isolation of infection. And so I've put together both PPE and I guess patient isolation because they're all sort of doing the same sort of thing. They're barriers between a barrier between the spread of infection between one place and another. Now, patients with resistant organisms or communicable organisms can be a reservoir of infection for other patients. It's really important to remember that the vector is often healthcare workers, particularly their hands. So isolating patients prevents direct transmission, so aerosol or droplet type spread, but it also prevents transmission on healthcare workers' hands. So it's an added sort of barrier along with hand hygiene to healthcare workers acting as vectors. Now, that picture there is me wearing PPE when we were doing our Ebola preparation tests. That is about as much PPE as you're ever going to see anyone wearing, and thankfully it's not necessary all the time. But I'll talk a little bit about the different sort of levels of PPE, and I've added a few more slides with some of the new complexities that COVID has brought around. The main barrier to isolation as an effective infection prevention technique is that people don't do it. So that can be recognizing that the patient has a communicable disease when they're in the emergency department. Those of you who have worked in hospitals or in hospital infection control teams will be very familiar with a patient with measles sitting in the emergency department for 4 hours and potentially exposing hundreds of people. It happens, frequently enough that I'm pretty confident that I can say it's happened in many hospitals around the place. Some of that is dealt with by active case finding by infection professionals, going through the ED sort of triage list and seeing if there's anyone who sounds like they might have anything potentially infectious and doing a quick round. Non-infection consultant medical staff frequently say, oh no, I'm sure that's not chicken pox, and I'm sure therefore that patient doesn't need to be in isolation, and sometimes they're right, and sometimes their confidence results in the exposure of staff and other patients to potentially communicable infections. Obviously, the level of PPE you apply has got to be appropriate for the pathogen that you're trying to isolate against. I guess the flip side of not putting people in isolation is taking them out too soon, like, oh, that test was negative, therefore we'll take them out even though the patient's still coughing and sneezing, and then the thing that you haven't tested for is then able to be communicated to another patient. And one of the real challenges is that most hospitals just don't have enough isolation rooms, and so there's this sort of complicated game of isolation triage where you need to work out who really needs to go into your 2 single rooms in your small hospital. It's also just important to remember that patients don't actually like being in isolation. Particularly children, find people who look like I looked like in that previous photo scary. Many, particularly older people who are in hospital, like being in a 4-bed base so they can have a chat. And, it makes the distressing experience of being in hospital significantly worse for some people, that they're stuck in a room by themselves and that everybody who comes in to see them looks like they're an astronaut in a spacesuit. Standard precautions used to be called universal precautions, but they're now called standard because they should be the minimum standard of care. They include hand hygiene, the appropriate use of personal protective equipment. Now, extra PPE falls under transmission-based precautions, which are on the next slide, but even with standard precautions, if, for example, you're doing something that could potentially expose you to blood or body fluid, then the recommendation is that you wear gloves. That doesn't mean you need to wear them all the time, but that having access to the appropriate level of PPE according to your risk assessment is a key part of standard precautions. Sharp safety, including disposal of sharps, attention to aseptic technique where appropriate, respiratory hygiene, cough etiquette, vaccination against all of the things that it's possible to vaccinate against, or as many of them as we can, and other sort of hospital, I guess, house functions, if you like cleaning and sterilising and waste management and linen handling. Now this little flow sheet I guess reflects the old understanding of transmission-based precautions, and I've got a few more slides coming up about how COVID has changed our thinking. Essentially, we consider there to be 3 categories of transmission-based precautions. So contact transmission is things you get from touching patients or touching the patient's environment where the infectious particle has settled on that surface. So things like cutaneous infections like Staph aureus, diarrhea, norovirus, that sort of thing, resistant bacteria, they are transmitted to your hands directly from touching the patient or from touching the patient's environment, and and therefore hand hygiene is key in getting rid of them. But when there's sort of contact transmissible pathogens, we sometimes put a few, the recommendation is that we put a few additional measures in place. Now, droplet transmission is where a particle, so the infectious particle is relatively large, often comes from the upper airway. So the particles are coughed or sneezed out. Because the droplets are large, they don't travel very far. They tend to fall within a couple of meters around the patient. And also because they're large particles, they're more resistant to drying out. And so you sneeze, droplets will fall onto the patient's tray and onto their bed and sort of sit there for a while. And if you come along and touch that, you will end up with those droplets with the pathogen on your hand. It is possible to be infected by droplet pathogen by breathing it in directly if you're close enough to the patient. If they cough or sneeze, or if they're just expiring infectious particles. Now, respiratory infections are the ones that we've always considered to be characteristically droplet spread. Things like flu and pertussis and initially COVID, although I'll talk about that in a sec. And then airborne or aerosol transmission is where those infectious particles are smaller. They often come from deeper down in the airways, and because they are what's called the droplet nucleus, although I'll call them particles because it's confusing using droplet for aerosol, it's so much smaller, it's able to remain aloft on air currents in the room. So whereas a large particle droplet is sneezed and falls to the ground, an aerosol particle is expired and floats around in the air for a while and tends not to settle so well. So it's much more able to be inhaled by another person and therefore cause infection directly. And also because the particle is smaller, when you inspire, it's able to get deeper down into the airways. The archetypal droplet spread infection is measles, and this shows how those particles can remain aloft for a long time because there's very frequent reports of what we call shopping centre measles, where someone infectious with measles goes to the shops, and then other people who just happen to be at the shops without necessarily having any very, very close contact with that infectious individual then go on to develop measles if they're not vaccinated. COVID has changed this a little bit. We previously thought that aerosol versus droplet was really a dichotomous thing. Flu transmitted by droplets, measles transmitted by aerosol, and there's really very little overlap. The pandemic flu guidelines often tended to recommend aerosol precautions just in case, because what if the new virus behaves a little bit differently? But early COVID guidelines, based on what we knew about other coronaviruses, really emphasised droplet protection over airborne protection. Now, that wasn't necessarily the wrong thing to do because coronavirus does predominantly spread by droplets, and that's certainly how the epidemic behaved in the early days. The pattern of droplet spread is infections in close contact. So, your family members, maybe your workmates or people in your classroom, but not this sort of explosive spread like you would see for a disease where there's no immunity, unlike measles, where people go to the shops and then all of a sudden there's 50 cases in the shopping centre. COVID just didn't behave like that, and so we thought coronavirus is usually spread by droplets. The epidemic is behaving like it's a predominantly droplet spread infection, therefore droplet precautions are probably fine. Unsurprisingly, it turns out that it's a little bit more nuanced than just a sort of a hard dichotomy. And this graph, I guess, is a neat way of illustrating that there are droplet infections, and these pathogens can spread via a range of particle sizes. And then there's infections that mostly spread by aerosols, and that they too can have a variety of particle sizes, some larger, some smaller. And so essentially droplet infections spread via large or sometimes medium particles, and aerosol infections spread by small and sometimes medium particles. And so then there's this sort of grey overlap zone in the middle. And so what that means is that sometimes infections which usually spread by droplets can spread by aerosol, and sometimes aerosol infections spread by droplets, but that doesn't matter so much because the aerosol precautions will provide good protection against droplets anyway. Now there's factors which, I guess, if you like, shift the droplet curve in this graph to the left. So it makes the possibility of aerosol spread greater. Or the other way that you can increase the likelihood of aerosol transmission of droplet, in inverted commas, infections is by increasing the size of that curve. So if there's a lot more infection around, then the area of the area of that normal curve that is above the aerosol threshold will be larger. So as I said, overall, the epidemiology of COVID is that it's much more likely that droplets have been driving transmission of COVID, but there have certainly been reports where there has clearly been aerosol spread. So it's not to say that it can't happen. And, I think this was really something that public health and infection didn't do well early in the pandemic is that we really didn't communicate very well about the risk. And it's technically complicated as well because, to lay people, sort of airborne infection includes both droplet and aerosol, and where professionals can be splitting hairs, the general public don't necessarily understand the nuance. So these factors that we talk about as increasing the likelihood of aerosol spread are called aerosol generating behaviours, which is really unfortunate because it implies that it's all on the source patient's end rather than there being other factors as well. So forced vocalising or shouting, so confused older people who are calling out, or a sick person who gets right up in your face and starts shouting at you, are more likely to generate aerosols, smaller particles as well as larger particles. Hospital procedures like use of nebulizers also increase the risk of these particles being generated. I've listed intubation there. It's very, very controversial. There is very strongly conflicting data. It's certainly probable that intubation does generate some aerosol-sized particles, but it really doesn't seem to be very high risk in terms of causing aerosol infection. So, if people are wearing droplet precautions, that really seems to mitigate most of the risk. And there have been studies in both directions that show, aerosol spread, aerosol or droplet particles being liberated through intubation. Now, as I said, not all of these are patient factors. The concentration of patients, essentially, the environmental viral load that you have, increases the likelihood of aerosol spread. So if you've got a single room, there'll be fewer particles in that room, and so more likely that most of them will be droplet size. If you've got a 4-bed bay or a Nightingale ward that's full of patients, then they're all expiring these particles, and so therefore there's likely that there'll be more aerosol sized particles just because of burden of disease. Ventilation is important, and I think that this is another area that we didn't necessarily do well previously. It's not just about number of air exchanges or degree of filtration. It's actually very complicated. Air exchanges are obviously important, and HEPA filtration, there's some experimental data but no actual real-world clinical data that it suggests that it reduces risk of infection, but it certainly reduces the number of infectious particles in experimental models. But as well as just air exchanges, there's also things to do with airflow design. So, for example, is your air conditioning intake vent just outside one of your isolation rooms and near to the door to the tea room? So, for example, in terms of sensible infection design, you want to put your isolation rooms away from the majority traffic area of a ward, because fewer people sort of mobilizing near the rooms is a way of mitigating the risk. So that means that your isolation rooms will tend to be down the end of the ward. What else do you put down the end of the ward? You put the tea room down the end of the ward because you don't want taking up important clinical space and you want it to be quiet and away from the rest of the ward. So if, for example, your your intake vent for your air conditioning is on the ceiling in the corridor between your isolation room and the tea room, whenever the isolation room anteroom door is opened, the air conditioning vent is going to suck stuff out of that anteroom and potentially drag it in the direction of the tea room door, which may increase the risk of infection in your staff. Now, ventilation seems to be touted very significantly as a fix-all for COVID. If we ventilated all our buildings properly, then COVID would just go away. To which I say that ventilation is very complicated, and it's very rarely possible to retrofit air conditioning in such a way to make it completely COVID safe very easily. And I'm not 100% sure that even the most ardent of ventilation advocates are really suggesting that we should bulldoze every building that has an old air conditioner and rebuild it from the ground up with new and improved ventilation. I don't think that's actually a feasible solution. One of the interesting things about, I guess, COVID and the perception of risk is that the risk hasn't actually really changed since the beginning of the pandemic, except through the volume of people that are infected. What has changed is people's risk tolerance. And so, the truth of how COVID spreads is somewhere on this slide. Now, as I said before, the epidemiology of the pandemic doesn't support COVID always spreading by aerosol, because we know that most infections are in close contact, and you need to be in a room with someone for a while most of the time, even if it suggests that it's more, aerosol infection is possible because someone down the other end of the room rather than someone 2 meters away gets COVID. The risk of that happening is much lower. So the pandemic hasn't been driven by only aerosol spread. I think it's reasonable to say that it doesn't even usually spread by aerosol, but it's definitely true to say that it's possible for it to be spread by aerosol. And so this is where this question of risk tolerance comes in. So, COVID can be airborne and COVID is always airborne aren't the same statement, and the precautions that you apply may be different depending on what your degree of risk tolerance is. So if your risk tolerance is 0 infections ever under any circumstances, then you're always going to use aerosol protection. If your risk threshold is using droplet precautions prevents the vast majority of infections the vast majority of the time, and we should do a risk assessment if there's any of those aerosol generating factors present, and then we should use airborne precautions, then that is, I guess it's a different sort of point on the risk tolerance scale, if you like. And, that is, again, perhaps too nuanced a discussion for, certainly for people to have on Twitter or on social media. And it's been a cause for a lot of confusion and a lot of angst for infection prevention and control people saying, oh, you're not keeping us safe. Whereas it's, perhaps a difference in risk tolerance. That's enough about COVID, although I will come back to the issue of fit testing masks when I'm talking about airborne precautions. All of the transmission-based precautions rely on standard precautions as their sort of fundamental bedrock, if you like. Contact precautions, as I said before, involve the use of PPE, so gloves and gown, to minimize the risk of your hands or your clothes being contaminated by the contact spread pathogen. Trying to minimize the amount of contact that people or things have with the infected room. So that means, the classic example is medical students putting on gowns and gloves and then going and leaning up against the wall in the patient's room. It's probably not super high risk because even though the gowns aren't often closed at the back, you don't come into contact with the back of your shirt very often during the space of a normal clinical day. Hopefully the students are wearing gloves and then they should wash their hands on the way out. But, that's the sort of thing to be mindful of with contact transmission. transmission. Single patient use equipment, so blood pressure cuffs and thermometers and tourniquets, that sort of stuff, minimise the risk of transmission between patients. And really importantly, and probably the one that I see done least well, is leaving the patient's notes or the computer on wheels outside the patient's room rather than taking it into the room, so it can then act as a fomite on wheels, or a manila folder covered in God knows what between rooms. Ideally, if there's enough single rooms available, which, as I said before, is rare, single rooms would be ideal, but not mandatory. So droplet precautions, again, standard precautions are fundamental. Ideally, a single room if possible, but it's not mandatory. So, bearing in mind what I was saying about particle sizes, if worst comes to worst and you've got a predominantly droplet spread infection, then, drawing the curtain between patients is better than nothing, but not ideal. Use of a surgical mask, getting the patient to wear a surgical mask if they're outside their room. So for example, if they're going down to medical imaging or somewhere else for a procedure or something, and wherever possible, single patient equipment, because they cough or sneeze or whatever when they're in the room, or the droplets are on the surfaces, and then staff touch those, get onto the tourniquet, for example, and then the blood person takes it into the next room. So and it acts as a fomite. So airborne or aerosol, I prefer transmission, because I think there's also been a lot of confusion with COVID, whereas people, lay people think that droplet transmission is airborne because it's not just by touching, it's by sneezing or whatever. So aerosol precautions include standard precautions, and especially being mindful about respiratory hygiene and cough etiquette. And an important thing is trying to absolutely minimize the exposure of staff to the patient. And, because the fewer people who are in the room, the fewer people that can potentially be exposed, because, we are aware that precautions are never 100% effective. This also includes, I guess, other sort of barrier in inverted commas methods, like if you've got someone with varicella, only getting vaccinated staff to look after the patient. Ideally, again, a single room with a negative pressure setup, with the required number of air exchanges per hour as per the Australian standards, without shared recirculation of air to other clinical areas, and an anteroom. So the negative pressure means that you open the outer door to the anteroom, and there's sort of limited capacity for mixing of the air in that room with the outside. But then when you open the inner door, any particles that have managed to escape hopefully get sucked back into the room, so that when the staff go back out, again, you open the inner door, and hopefully the infectious particles are staying inside the room rather than being sort of drafted out into the anteroom and then getting out into the corridors. And finally, the other part of airborne precautions is a well-fitting respirator prior to patient care. And so this is one of the other things that's been controversial during COVID, which I'll talk about a bit now. The logical follow-on from COVID is airborne is that everybody needs airborne precautions, and that ideally everyone who's using a P2 or N95 respirator has had a fit test prior to use. So fit testing is a way of determining which sort of mask gets the best seal on your face. So different masks have different shapes, have different sort of elastic characteristics. People have obviously an infinite variety of facial shapes, and not every mask is going to work for every person. And so a fit test is a mask that's got like a little sort of nubbin on the front, essentially, that you hook up to a fit testing machine, which sprays some particles into the mask and then assesses to see whether it leaks when you shake your head and nod and lean forward and do all these other sorts of random face movements. So a fit test tells you which brand of mask has the best chance of giving a good seal to your face. Now, the second part of ensuring good fit is what's called a fit check, which is not a complicated procedure at all, but it's done at the time you put the mask on, and you basically conform the mask to your face, you give it a bit of a squeeze, and then you take a few vigorous breaths to see if there's any leakage of air. Now, again, how you interpret this discourse is very different depending on what your risk tolerance is. So the people who were more risk averse said, well, fit checks are useless because they're not scientific. It's just some random sort of thing you're doing to see if the mask fits. And unless we've got scientific proof that the mask is a good fit, doing a fit check is pointless. The other way of looking at it is, regardless of how well your mask is fit tested, if you don't fit check, then the fit test was pointless. So you can, no mask will get a good seal if you don't push it down and sculpt it to your face. And you should never assume that your mask is going to provide you good protection unless you've actually done a check to make sure that it's working properly. And so again, this was a cause of a lot of angst for hospital infection control practitioners. Obviously, we want everybody to be fit tested if possible, but when you've got 50,000 people who work for Queensland Health, and most of them were last fit tested in 2009 during swine flu, and they all need fit testing right now, and fit testing needs specialised bit of equipment that nobody actually knows how to use, that you've got to buy or outsource to some training company who are charging lots and lots of money and contracting their services to every hospital in Queensland, it's not actually physically possible to fit test everybody all at once. So this was, again, like I say, it caused a lot of angst. People said, oh, well, I haven't been fit tested, so I'm not going to come to work because it's dangerous. But, fit checking is the sort of the mandatory procedure. You can probably tell that I guess I'm more down the pragmatic end of the risk spectrum, and my personal take is that I don't believe there's any point in members of the public wearing respirators, because unless they're healthcare workers, no members of the general public have been fit tested, and very, very few members of the public know how to do a good fit check. And it may come as a bit of a surprise, but there's actually not an enormous amount of data about N95 versus surgical masks for COVID specifically, and for respiratory tract infections in general. Most of the data that do exist, it's small studies, difficult to interpret, but it's very likely that respirator, an N95 mask that is not well fitted, does not provide better protection than a surgical mask. So I think members of the public should only be wearing surgical masks. We ideally, as I said, want to fit test all healthcare workers. However, it's not necessarily possible to fit test everybody all at once. If you're having to risk assess your fit testing program, then you want to focus on the highest risk people first. So respiratory ward, COVID ward, intensive care, infectious diseases, emergency department, those are the people who need to be prioritised. And remembering that the Australian standard for fit testing is actually clean shaven if they're men, without any extra, theoretically, without any extra bits of tape or anything, or padding to try and reduce the impact of pressure areas, and that it actually needs to be repeated on an ongoing basis if people's face changes shape, like they've lost or gained weight, and ideally every year. When I'm presenting this talk in person, I give a bit of a demo on this slide. It's just here to remind people that taking off PPE is almost as important as putting it on, that you need to take care not to contaminate your hands when you're removing PPE, that it's important to try and minimize handling of PPE and then touching your face, because that's when you're most likely to transmit droplets to your mucous membranes, and that if you are diligently removing your PPE, then there are actually multiple hand hygiene steps in the process. So ideally taking off your gloves, rubbing your hands, removing your goggles, and so putting your hands near your face immediately after you've washed your hands, and trying to minimize the risk of you handling a contaminated piece of PPE and then putting your fingers near your face. That's probably enough on PPE. I've got a couple of slides now on surveillance. So our labs will identify multi-resistant organisms and usually provide a list of those to the infection control practitioners, who then do a case review. And as I was saying before, try to do a determination on whether it's healthcare associated or not, whether it's been previously isolated in another hospital or not, and then collating the data and doing reporting. And this is just a slide showing the progressive increasing rate of VRE in hospitals throughout Queensland, in the early 2000s. Unfortunately, we don't have standardised Queensland surveillance definitions for healthcare associated infection. It'd be great if we did. As a rule of thumb, an infection which occurs 48 hours or more after admission and which wasn't incubating at the time of admission. So for example, if you've got a fever when you come in and then you develop a bloodstream infection on the third day of your admission, and there's no other obvious cause for the fever, then that was probably a community-acquired bloodstream infection. That's sort of the rule of thumb cutoff that we use for healthcare associated. As I said, not previously identified in another facility, and highlighting what I said earlier on about increasing complexity of care means that you can have, if you come in today, the day chemo suite for your chemotherapy and go home and then get an infection 3 days later, that's probably still healthcare associated, even though you've been incubating it at home, because you've had that degree of healthcare contact. So it requires a little bit of judgment. It's, one of the bits of art and science of infection prevention control. One of the things that we monitor is bloodstream infections, because they're a major cause of morbidity and mortality. As I said before, Staph aureus bloodstream infections have perhaps a 20% mortality rate, and there's about 7,000 of them a year in Australia. Any hospital associated bloodstream infection has an attributable mortality of probably around 35%, so very, very significant cause of disease. And coming back to what I was saying about the preventable hospital complications, there's many factors that contribute to patients' risk of developing bloodstream infections. So their degree of comorbidity, what disease process they're admitted with. So someone who's admitted for chemotherapy for an acute leukemia will almost invariably develop a bloodstream infection at some stage during their admission, whether they have IV lines, PICC lines, central lines. And it's very likely that some of these bloodstream infections are going to be preventable, but I just don't think it's possible to say that they should be a never ever event with the way that we deliver healthcare at the moment. One subset of bloodstream infections that I think we should be able to almost entirely prevent is IV associated bloodstream infections, or what we call catheter associated bloodstream infections. They're a major cause, obviously, because you've got a little plastic straw hanging into your vein, creating communication where one doesn't normally exist. Every hospital needs to have policies for line insertion and maintenance. I'll talk in a sec about the central line bundle, which is another multimodal intervention, which is a way of reducing the risk of central line associated bloodstream infections. Obviously, educating, that shouldn't just say nursing staff, it should say all clinical staff about line care. And far and away, the most important one is removal of lines when they're not necessary. Catheters, cannulas that are left in just in case you need them, are serving no meaningful purpose other than increasing a patient's risk of infection. Always take them out when they're not needed. You can always stick another one back in if you need to. So the central line bundle is sort of, I guess, the most well-described multimodal infection control intervention. You can see all the points there. It includes, aseptic technique of, sterile gowns and gloves and what have you, good hand hygiene beforehand, using Chlorhex for that residual antibacterial effect that I was talking about before. Site selection is actually really important. Those of you who work in the emergency department will know that femoral central lines are the preferred site because they're quick and easy to do, and they have the lowest rate of mechanical complications from insertion. So, fewer immediate side effects like bleeding and pneumothorax and all that sort of stuff. However, femoral lines are much more likely to get infected because they're in people's gross sweaty groins. And if you look at the entirety of the duration, the dwell time of the central line, then femoral lines are clearly substantially less safe than either jugular or subclavian lines, except at that very initial point of insertion. As I said on the last slide, daily review, removal when no longer needed. That's another downside of femoral lines. They can easily be forgotten under the patient's blankets because we don't routinely examine our patients' genitals on the wards every day. And the use of the complete sort of package of the central line bundle reduces rates of catheter-related bloodstream infection by somewhere between 30 and 95%. And as well as being clinically effective, it's also found to be cost-effective. Now, interestingly, when you look at any individual component of the central line bundle in isolation, it's nowhere near as good and most of the studies don't reach statistical significance. But using the whole of the bundle is associated with a substantially lower rate of bloodstream infections. Just a couple of quick slides on some of the other components. So staff health, obviously we want to monitor rates of occupational exposures, so needle stick injuries or other bloody fluid exposures, and important to apply some public health thinking about these and work out if you're having an outbreak of exposure. So for example, do you have a new surgeon who is getting a lot more needle sticks than his peers? Why might that be? Is he doing some sort of new technique that involves greater risk, or what else might be going on? Staff vaccination is incredibly complicated and could be a whole talk on its own. And something that COVID has hopefully changed for the better, as well as our understanding of transmission dynamics, is the zero tolerance for healthcare workers coming to work when they're sick, which I hope will be a persisting change, but I fear will not be. Part of what I like about infection control is the fact that there's a little bit of clinical science, a little bit of microbiology, a bit of human behavior science, and also some industrial stuff. Hospital environment is actually very complicated. There's been studies that show that good hospital cleaning programs reduce your rates of healthcare associated infection, but it's much, much more than just ensuring that the patient's rooms are well cleaned. You could give a whole lecture just about the role of the sink in hospital infection prevention. Just two brief sort of comments on sinks. Number one, that they can potentially be reservoirs for infection. There's a well-described outbreak of multi-resistant gram-negatives in an ICU associated with contamination of the water in the S-bend of a hospital sink. Then if you've got a sink with a very shallow bowl and the water coming out of the tap going into the plug creates the risk of splashing water up from the S-bend onto your hands when you're washing them, then that can potentially turn a clean, in inverted commas, hand after hand washing into a contaminated sort of vector of disease. The other comment about sinks is just how important it is where you put them. If you put your sink in an alcove down the back of the ward so the wardies don't knock it off the wall pushing a bed down the corridor, it's much less likely to be used. And I guess the optimum placement of sinks in newly designed wards is to ensure that a clinician can't get from the nurse's station to the first patient room without at least walking past one sink, because seeing that sink there or the alcohol-based hand rub above it is like, oh, I should wash my hands, and make it easy. Where if you have to walk past your patient's room to go to the sink further down the corridor, you're just not going to do it. The other way around that, of course, is to put the bottles of alcohol-based hand rub on a clip on the end of every patient's bed, and then when you're with the patient, you've got the means to do hand hygiene in front of you. Infection control teams get lots of complaints about dirty walls or mold around air conditioning vents, except in hyper-specialised units like bone marrow transplant units or haematology wards. Really, it's probably not of clinical significance vast majority of the time. But the issue that I was just talking about with the sinks is a really important reason that there should always be someone from infection control on your hospital's redesign team. It's not just about looking at plans, it's about ensuring that staff movement and airflow, now that we're paying much more attention to ventilation and sink placement and all that sort of stuff, is in as good a way as it can be to optimize the chances that people will be carrying out good infection control. I'll just talk a little bit about antimicrobial stewardship because there is a separate talk on it. Now, the resistance of predominantly bacteria, but also viruses and fungi in the community and in hospitals is increasing. You can see that in the top graph there, which is from a an American report a good number of years ago now. And the bottom graph shows that the number of new antibacterial agents approved by the US FDA has been declining very steadily. That's really a very much a financial decision on the part of the drug companies. They don't want to invent new antibacterials that you take for 5 days and then you're cured, and that is assuming that your antibiotic stewardship doctor will let anybody actually use the new antibiotic, because that's not a very good financial return on investment. If you come up with a new medication for a chronic disease that the patient needs to take every day for the rest of their life, then they'll make a lot more money out of it. So sadly, it has really come down to finances as a significant part of the reason that we're not seeing any new antimicrobials. So what is antimicrobial stewardship, other than a terrible term which I really dislike, but I'm kind of stuck with it now, unfortunately? It's the ongoing effort by healthcare institutions to optimize antimicrobial use. And when you talk about optimizing antimicrobial use, it's important to highlight that optimal antimicrobial use is optimal use for an individual patient. Good antibiotic use improves individual patient outcomes. There's this broad perception that AMS is about reducing resistance primarily, and that means that an individual patient might get less good care so we're sparing antibiotics to try and prevent resistance. That's not what it's about. It improves individual patient outcomes. Cost-effective therapy is a minor issue because antibiotics are actually really cheap. You've got to stop an awful lot of antibiotic to save yourself any money, but also to reduce the adverse effects of antimicrobial use. Again, individual patients, so toxicities, adverse effects, allergies, and also antimicrobial resistance at a community level. And finally, all hospitals now must have an antimicrobial stewardship program in order to pass their accreditation. Despite the perception from prescribing clinicians who believe that stewardship programs are about locking up the meropenem and stopping them from using it, it's not just about formulary restriction, although that is a part, it's a small part. Education is critical, involvement in the production and management of hospital guidelines, direct prescribing review and feedback, so looking at the prescribing of antimicrobials in a facility and then providing feedback to the prescribers, closing that surveillance loop, some formulary modification or restriction, and the requirement for pre-approval for some antimicrobials. Those are all considered to be sort of core parts of an antimicrobial stewardship program. Does it work? Yes, it does. This is a very complicated graph. The blue bars are rates of Clostridioides difficile diarrhea in a hospital in Canberra, so in Canada, sorry, rates per 1,000 patient days, or incidents per 1,000 patient days. The yellow wiggly line is the rate of antibiotic use that are particularly high risk for promoting C. diff. And you can see that there was an increase in the rates of C. diff throughout 2003 until enhanced infection control interventions were introduced in September. So, single room, aggressive isolation of anyone on contact precautions with any abdominal symptoms, widespread testing for C. diff, hand hygiene blitz, all that sort of stuff. And that you can see between September 2003, April 2004, the rates of C. diff really didn't change. Then in April 2004, during the green bar, there was a crackdown on the use of the antimicrobial agents that are particularly prone to promote C. diff. And you can see that the rate of usage of those antibiotics dropped down very quickly, and also the rate of C. diff dropped off very quickly too. Now, some of that was probably the lag effect from the infection control interventions, but you can see that as the rate of high-risk antibiotic use remained low, so too did the rates of C. diff in that hospital. This is another graph showing very similar sort of figures from a hospital that I worked at when I was a trainee in Brisbane. You can see that the rates of ESBL Klebsiella in this hospital, this is a count, not a rate, were up to between sort of 8 and 10 isolates per month in the mid-90s. You can see in about mid-1995 there was a formulary restriction where, again, the use of the highest risk antibiotics for promotion of ESBL were heavily restricted in this hospital, and that fairly soon afterwards the count of ESBLs per month dropped to somewhere between 1 and 2, maybe 4 in a bad month. So stewardship definitely works. So just in conclusion now, all medical care has the potential to cause harm, and the role of infection control is to minimise as much as we can these harms. Education is really, really important because hospitals have very short corporate memories, and it's a real struggle when it's seen as getting in the way of clinical management rather than being part of good clinical management. Good communication is vital. Communicate with your patients and explain their need for isolation. Communicate with your colleagues and explain what you're doing. Make sure you're closing that surveillance loop. And remember the tale of Ignaz Semmelweis. If you're too undiplomatic, you might end up being beaten up and thrown in an asylum. Hand hygiene works. We need to do it, and we need to do it better. The care is complex now, and the sort of the lines between inpatient and outpatient care are blurring, and we need to, I guess, deal with these challenges, as well as growing antimicrobial resistance and emerging diseases like COVID and whatever the next pandemic is going to be. And that public health thinking is very helpful in good hospital infection control. So better liaison between infection control and public health, between infection control, public health and primary care is really essential, particularly with the growing threat of drug resistance.